Welcome to this presentation on Blenderized tube feeding for patients with head and neck cancer. I'm Dr. Teresa Johnson, a professor and registered dietitian in the Department of Kinesiology and Health Promotion at Troy University. Today we'll quickly review the following objectives. We'll define Blenderized tube feeding, recognize its potential for efficacy in patients with head and neck cancer, and address potential concerns. As we learned from videos 1 and 2, head and neck cancer includes malignant tumors in or around the throat, larynx, nose, sinuses, and mouth. This patient population often needs surgery, chemotherapy, and/or radiation therapy. This cancer and the treatment modalities have significant nutritional impact, causing difficulty to maintain nutritional status and many times requires a tube feeding. Nutritional goals for patients with head and neck cancer include to maximize nutritional intake, this is both oral and via tube, to prevent or limit weight loss, to preserve lean body mass, to minimize treatment delays, and improve treatment outcomes. To meet those nutritional goals, patients are provided nutritional counseling and oral supplements. They're encouraged to participate in physical activity. Specifically, many organizations recommend 30 to 35 calories per kilogram body weight. Some research has demonstrated this is not adequate to prevent weight loss, particularly in head and neck cancer patients undergoing active treatment. The patients that we observed in our research were given a goal of 40 calories per kilogram of body weight per day. For further reading on these recommendations, the attendee is referred to the references at the bottom of this slide. Unfortunately, less than half of head and neck cancer patient populations meet these nutrition goals. Consequently, many will need nutrition support, usually by tube feeding. This is indicated when oral intake is less than 60% of estimated energy needs for more than 10 days. A PEG is the best option when enteral nutrition is required for more than 3 to 4 weeks. Unfortunately, 60% of patients report significant weight loss regardless of prophylactic or reactive tube feeding placement, and significant weight loss during treatment is an independent predictor of survival. For the past 50 years, commercial enteral formulas have been the go-to option. However, the message of diet diversity has resonated with the tube feeding community, and they want this for themselves or family members requiring a tube feeding. Patients and caregivers are reporting generally positive outcomes from a whole food-based tube feeding substrate. The reports of BTF's safety and efficacy are more frequently reported in children, but evidence is also emerging in adult populations. And this graphic illustrates the mounting evidence of BTF efficacy and safety for improving patient outcomes. Blenderized tube feeding options represent the ultimate in feeding diversity. Patients may opt to make their own formula using recommended recipes. They might add baby food to a commercial formula, or they might utilize one of more than a dozen commercially prepared blenderized tube feeding products that are now available on the market. In the truest sense, however, a blenderized diet is simply food, and perhaps a vitamin or mineral added to it, pureed in a blender and given via tube. There are no additives or preservatives. Today I want to describe the potential impact of using BTF in patients with head and neck cancer. Of course, research is very limited, but promising as we will see. First, let's examine a retrospective chart review study that was published in 2017. Researchers followed patients with head and neck cancer for 8 months. The group of 212 subjects was initially divided into 2 groups, a commercial formula-fed group of 181 patients and a group of 31 patients given a recipe to make blenderized tube feeding. However, during that 8-month period, 69 patients in the original commercially fed group switched themselves over to a blenderized tube feeding. They were not provided oversight or assistance with this switch, so the BTF composition was unknown. This resulted in 3 comparison groups at the end of the 8 months. BMI declined in all 3 groups by week 8, but the greatest decline was in the group that switched themselves to a blend. the researchers concluded that blenderized tube feeding was not adequate to support weight in the oncology population. However, a closer examination of the paper revealed that both the initial commercially fed group and the BTF groups were encouraged to add food to their tube feeding, so we don't really have a true comparison. Also, the BTF group had very little oversight with their feeding compared to those that were fed commercial enteral formula. This likely accounts for the differences more so than the feeding substrate. In partnership with colleagues at Mayo Clinic, Rochester, and the Montgomery Cancer Center in Alabama, we conducted an open-label prospective study of head and neck cancer patients given a tube feeding at the initiation of chemoradiation treatment. The plan was to assess GI symptoms, quality of life indicators, anthropometric and oral intake at 3 points in time over 6 to 8 weeks. The first 2 weeks, patients were provided with standard commercial formula. At the end of the second week, patients were to replace half of their commercial formula with a commercially prepared blended tube feeding product. This was to be used for 3 weeks, and then the patient would switch back to 100% standard formula for a couple of weeks. We enrolled 30 patients, and 16 were able to remain in the study for the full length of time. However, after 3 weeks on the blend, no patient wanted to return to full commercial formula feeding. All except 2 patients wanted 100% of the BTF, not partial. So we amended the study protocol and proceeded. Although we were only able to get 16 to the finish line, no one withdrew due to issues with the blenderized tube feeding. Our results were quite encouraging. BMI scores improved or held steady for 56% of the subjects. By the end of 6 to 8 weeks, there were no reports of GI issues. Oral intake and overall calorie intake was improved when BTF was added. What we typically observe in this population is that weight drops dramatically after the first 2 to 3 weeks of chemoradiation therapy and persists for weeks and months afterward. But in our study, we observed a weight rebound that began 1 week after adding BTF. The potential for a blend to arrest weight loss at a critical point in chemoradiation therapy has implications for post-treatment outcomes. Issues with clogged tubes or increased caregiver demands were minimal. Quality of life improved, and this is evident by the fact that the patients preferred the blended product over the commercial product and wanted to remain on it indefinitely. We observed that with the addition of blenderized tube feeding, oral intake improved and adverse GI symptoms declined. Again, these observations are in direct contrast to what is typically reported in the literature of head and neck cancer patients requiring nutrition support. We, of course, had some limitations to our study. Although we enrolled patients over a 2-year period, it was difficult to get them through the full 6 to 8 week period. As one might expect, the head and neck patient population is very complex. Reasons for non-completion included interruption due to need for hospitalization or lack of need for nutrition support for the whole time, or patient death. We also had difficulty getting complete records due to the impact of COVID and the fact that some patients were too frail to collect anthropometric measurement. Nevertheless, the patient experiences cannot be ignored. The statements provided by those in the study on this slide are not cherry-picked. We had no negative comments from any study participant. How might blenderized tube feeding provide these provocative outcomes? We don't know for sure, but diet diversity, particularly diets high in fruits, vegetables, and whole grains, improve the intestinal microbiome that favor growth of beneficial bacteria that in turn is associated with better health outcomes. If future larger studies confirm these findings, BTF may well help ameliorate the side effects of treatment and serve as a teachable moment to cancer survivors that improving diet quality is to their advantage. Indeed, BTF supports the language of the American Institute of Cancer Research that during and after treatment, patients should consume a diet with a variety of foods, including fruits and vegetables, and limited in processed food, sugar, and alcohol. Unfortunately, a paper published in 2021 indicated the healthy eating index scores of cancer survivors is quite low at 55.6 out of a possible score of 100. We can't have a conversation about BTF without addressing a frequently cited concern, and that's the potential for bacterial contamination in homemade blenderized tube feeding. Most of the papers citing high levels of BTF bacterial loads were published from countries where safe food handling is quite different than what might be expected in developed countries. We conducted 2 studies in the United States, one in the hospital setting and one in the home setting. In the hospital study, BTF samples met the same criteria for safety as commercial formula. In the home study of blenderized tube feeding, where we made it in 50 different homes, 88% of the samples met USDA standards, and the 2 samples that were contaminated did not exceed 10 to the 5 colony forming units, meaning that even those samples were relatively clean. Our studies stand in stark contrast to most published work and demonstrate that BTF can be safely produced and provide benefits of pre- and probiotics found naturally in food. Healthcare providers have been reluctant to recommend BTF because of the concerns listed on this slide. However, they rarely encounter them in clinical practice. The BTF community is very passionate about their interest in use of real food, and they need the support of healthcare providers, especially dietitians. Facilities prohibiting its use should reconsider their policies lest patients go it alone. I think the first study that we reviewed shows just how lack of oversight can adversely impact patient outcomes. Just as dietitians are involved in consideration of the best type of commercial formula, they should also be involved when patients want to consider using a blend, as not everyone is an appropriate candidate. Dietitians working in the oncology population should consider the composition of commercially prepared formulas with specific attention to ingredients that impact chemoradiation treatment. For example, turmeric can potentially increase or decrease the effectiveness of chemotherapy. Camu has increased levels of vitamin C, which is not recommended in supplemental form during radiation. Furthermore, not all commercially prepared blenderized tube feeding products are the same. BTFs that have the least amount of processing, additives, and preservatives are more likely to mimic a true homemade blenderized diet. Dietitians need to pay attention to the blends made by caregivers with specific regard to ingredients, calorie density, and volume needed to achieve nutrition goals. They need to look at nutrient analysis and overall cost. So the key takeaways are that patients with head and neck cancer most often need nutrition support, meaning that they may require tube feeding during and after treatment. When considering the formula, dietitians need to be knowledgeable and consider blenderized tube feeding. BTF improves symptoms, provides adequate nutrients to restore nutritional status and quality of life. It can be a home blend, baby food based, or a commercially prepared product, and a number of resources are available to help the RD help that patient interested in using a whole food tube feeding. And I would refer you to a growing body of evidence about blenderized tube feeding. This educational offering was provided to you by Aspen and supported by Nutrition North America. Thank you for attending today's presentation.